function, has good performance status, goes to Pilates every other day, and we evaluated her for pancytopenia. What is the reason? So the bone marrow biopsy shows 10% blasts with monosomy 7, ASXL1 mutation. Note there is no TP53. And by IPSS-M and IPSS-R, she is higher risk MDS. So she's actively considering stem cell therapy as part of her treatment plan. And she is asking me a few questions. Do I need treatment before stem cell treatment? Or what is if stem cell treatment is not an immediate option, what are the other options available? So stem cell therapy, clinical trials, hypomethylating agents, and targeted agents are the recommended options for first-line treatment in patients who are eligible for stem cell transplant in higher risk MDS. And azacitidine-ivosidenib combination in selected patients, it's about 5% of the patients who have IDH1 mutation. Those patients are treated with azacitidine-ivosidenib, or clinical trial, which is always the first option, followed by stem cell transplant, and HMA plus or minus venetoclax, and high-intensity treatment. So in 2021, there were two sister papers published in JCO. So these are two biological assignment trials. So this is the next best evidence other than the randomized control trial. So in these two papers, what happened was they assigned the patients according to the donor availability. So those patients who had the donor immediately were assigned to the donor arm, and those who did not were assigned to the no donor arm. So the no donor arm were treated with hypomethylating agents or best supportive care. So in this paper, this is a study by BMT CTN network, and what they did was if stem cell transplant is an effective option in MDS, because stem cell transplant in MDS, in higher risk MDS, is often underutilized, and many of these patients do get treatment after treatment without even seeing a transplant physician. So as you can see, there were 384 patients who were enrolled in this study, and 260 were randomized to the donor arm, and 124 patients were in the no donor arm. And primary endpoint was 3-year overall survival. As you can see, the donor arm is represented by the blue line, and the no donor arm is represented by the orange line. You could see that there was an absolute improvement in overall survival in the donor arm, and this was true across all subgroups that were analyzed. So make sure that we should ensure that all of our patients who are high-risk MDS and who have good performance status do see us leukemia physicians and the transplant physicians at the same time, so that these processes can happen in parallel. Now the next question comes, okay, while this patient waits for transplant, do I need to do something? Or is there any other medication that I need to be using? So this is a study from the German group. This is also kind of the similar setup as donor and no donor arm. However, this study has 4-month lead-in period with azacitidine. Azacitidine followed by reduced intensity stem cell transplant. So the patients 81 patients were in that arm, azacitidine followed by stem cell transplant, as opposed to continuous azacitidine in about 27 patients. So stem cell transplant after azacitidine significantly improved the event-free survival. The overall survival did favor the stem cell transplant, but did not reach the statistical significance. However, the most important point to note was the investigators looked at the patients who were in the 4-month lead-in period, and in which the 33% of the patients did not proceed to stem cell transplant. The reason being, half of these patients dropped out because of disease progression, and half of these patients could not go to transplant, or there was a delay in transplant due to infectious complications. So the take-home message from these two studies are, stem cell transplant does remain the only curative option. Azacitidine does improve survival, but does not prevent inevitable progression of the disease. And bridging with multiple azacitidine cycle does risk the losing the transplant opportunity. So the next question we need to ask ourselves, or I ask myself, is like, okay, this patient has 10% blast. Do I just wait, or is there any utility in downgrading this patient's blast? So this study was published in Blood last year. Does IPSSR downstaging before stem cell transplant improve the prognosis? So this is an EBMT study, and you could see these three curves, and the untreated, which is represented by the red line, chemotherapy, which is represented by the blue line, hypomethylating agent by the green, and the purple with the other. So the curves are showing same number of blasts, improving number of blasts, and blasts progressing on treatment or no treatment. So you could see that in the same number of blasts, you could see the first curve, which is the red and the green curve, are just the same, and other, which is the blue and the purple curve. So you could see that the survival is just the same in untreated. If the blast number is the same, it's improved in both untreated as well as for hypomethylating agent. So improving, in blasts that are improving, you could see that the blue line tops over the rest, and the blue line is represented by the chemotherapy. So the change in bone marrow blast is prognostically relevant mainly in the chemo-treated patients. And the next curve is if the blast number is increasing. Untreated patients does have better survival compared to the rest of the treatment options. So there is limited benefit to IPSSR downstaging or reduction of bone marrow blasts after chemotherapy, and there is no benefit for hypomethylating agents or other treatments. So the point of this discussion is if your patient is ready to go for transplant, do not delay transplant for any other therapy, just get the patient to transplant, and that remains the only curative option in high-risk MDS. So what for non-stem cell transplant eligible candidates with higher risk MDS, what are the treatment options that are available? So clinical trial remains the first option, and azacitidine is the category 1 recommended by the NCCN, and decitabine plus or minus venetoclax, oral decitabine cedazuridine plus or minus venetoclax, and for a selected subset of patients, azacitidine with ivosidenib or olutasidenib is a category 2B recommendations for these patients who are not transplant eligible. So my patient, Ms. Rivera, she is considering enrollment in a clinical trial because, as I said, she is a patient of Cuban origin, and they do have less of a donor pool compared to the Caucasian pool. So this patient is interested in pursuing a clinical trial. So what type of treatment should be pursued given her high-risk status? Is pursuing treatment with a BCL2 inhibitor still an option? So what is the rationale for combining BCL2 inhibitor with hypomethylating agent? I'm not going to discuss about the mechanism of action of venetoclax, just to say a short blurb, which is it is a BH3 mimetic, and it is a selective BCL2 inhibitor and acts on the apoptotic pathway. So what azacitidine and venetoclax acts synergistically because azacitidine primes the cells for the cell kill by the venetoclax. It does upregulate the pro-apoptotic genes, and the venetoclax inhibits the anti-apoptotic genes, enhancing the cell kill by this combination. So this is the study that all of us were eagerly waiting for, and this is phase 3 Verona study. This is a combination of venetoclax with azacitidine in higher risk MDS. 500 patients with newly diagnosed high risk MDS were randomized in a 1-to-1 fashion to venetoclax 400 milligram daily or given on day 1 to 14 with azacitidine as a 7-day cycle. And the control arm was with azacitidine monotherapy. So the primary endpoint of this trial was overall survival. Responses were assessed according to the IWG 2006 criteria. The key secondary endpoints included overall response rate, which is a combination of complete remission, partial response, and marrow CR. Overall hematological rate, red cell, and platelet transfusion independence rate were the other key secondary endpoints. So no significant difference in overall survival between the Win-AZA combination as opposed to AZA monotherapy was observed. As you can see, the overall survival was kind of similar in the combination arm as opposed to the AZA arm. This was presented in this year's SOHO by Dr. Garcia-Manero. So the overall response rate, even though the survival was not significant, the overall response rate was higher in the combination arm as opposed to the AZA monotherapy arm. As you can see, there was the overall response rate was 76% as opposed to 57% in the AZA monotherapy arm. And you could see the overall hematological improvement and transfusion independence was higher in the HMA venetoclax arm as opposed to the AZA monotherapy arm. And this is the subgroup analysis. You could see that when AZA arm was favored in most of the subgroups except the baseline bone marrow blast of less than 5%. And you could see that almost all of the ASXL1 mutation, venetoclax is ASXL1 mutation, EZH2, RUNX1 mutation, they are all sensitive to the HMA-Ven arm as opposed to the AZA monotherapy arm. So there is an updated ASH abstract that is being presented by Dr. Garcia-Manero in this as an oral. Subgroup analysis did show a trend towards a higher overall response rate in the HMA-Ven arm in patients with 5% blast and mutations in ASXL1, TP53, or RUNX1. And marrow CR with hematological improvement, which is a near complete response, was higher with HMA-Ven arm as opposed to the AZA monotherapy arm. So the one I discussed was the prospective study. This is the retrospective analysis. This is going to be presented as an oral abstract on Saturday. And this is 19 US academic centers that evaluated patients with higher risk MDS treated with frontline HMA venetoclax or HMA alone. As you could see, the survival outcomes were better with HMA venetoclax compared to the HMA monotherapy alone. And you could see that the post-transplant and the blast 10 to 19% and TP53 wild type, ASXL1 mutated, they were all very sensitive to treatment with HMA venetoclax, and all of them attained statistical significance. So what is the next role for BCL? What is the next step for BCL2 inhibition in higher risk MDS? So this is lisafloclax. This is a next generation BCL2 inhibitor that is being evaluated in patients with higher risk MDS. So this phase 1b2 study combines lisafloclax with azacitidine in patients with newly diagnosed or previously venetoclax exposed myeloid malignancies, including higher risk MDS. The primary endpoints for phase 1 was a safety, tolerability, and DLT, and to identify the recommended phase 2 dose. And for the primary endpoints for phase 2 were efficacy of this AZA with lisafloclax in AML, MPAL, chronic myelomonocytic leukemia, and higher risk MDS. Lisafloclax with azacitidine was active and well tolerated in patients with high-risk MDS and other myeloid malignancies. As you can see, the overall response rate, this stacked bar plot shows those patients who were relapsed refractory to venetoclax. That means they have already been exposed to venetoclax. The overall response rate in this population was 31.8%, with a CR/CRi of close to 22.8%. The AE profile was sort of similar to the HMA venetoclax arm, so it's about in about 70% of the patients with AML-MPAL and about 60% with MDS-CMML. Febrile neutropenia was noted in about 30% in AML-MPAL and 20% with MDS-CMML. So this is the updated abstract that is being presented as a poster in this ASH. This is for just high-risk MDS and CMML. This is about 15 patients. And The overall response rate in this population is 80 with equal responses for equal rates of response for both complete remission and marrow CR. Lisaftoclax may potentially overcome the venetoclax resistance in the venetoclax exposed patients with myeloid malignancies. Thank you. So this is the ongoing phase 3 GLORA-4 trial. This is assessing the lisaftoclax with azacitidine in higher risk MDS. There are some unique aspects of this study. Patients with newly diagnosed high-risk MDS are randomized to both lisaftoclax and azacitidine arm and the aza monotherapy arm. So the primary endpoints, there are two co-primary endpoints to this study, the rates of complete remission and overall survival. The responses are assessed based on the new IWG 2023 criteria, and the secondary endpoint would be safety evaluation. So what are the take-home from Verona and future directions with BCL2 inhibitor? And do I still use a HMA-venetoclax combination in these patients? Absolutely. So in the Verona trial in high-risk MDS, the primary endpoint was not met, which is a disappointment. However, this population also included patients with low blast, TP53, and significant use of stem cell transplant. We should keep in mind that the VLA was positive because most of that was evaluated in transplant ineligible population. So almost all the patients were enrolled were 75 years and older. There were only like a fraction of the patients who went to transplant. So that is the significant use of stem cell transplant probably played a role here as well, because most patients on both arms, which is the aza monotherapy as well as the aza-ven combination arm, did go to transplant. A higher proportion of patients treated with ven-aza achieved higher response rate and marrow CR with hematological improvement, and numerically lower risk of AML transformation as opposed to those treated in the aza monotherapy arm. The subgroup analysis did show favorable trends in response for venetoclax and azacitidine in younger patients, patients with excess blasts, and select mutations such as ASXL1, splicing factor mutations. As we already know, additional therapies are needed direly to treat newly diagnosed patients or prior ven-exposed myeloid malignancies such as MDS, and GLORA-4, which evaluates the newer generation of BCL2 inhibitor, is open and actively enrolling in the United States. Consider a patient age 65 years with high-risk MDS, such as monosomy 7, ASXL1, who cannot proceed to stem cell transplant immediately due to a delay in donor search. Assuming all options are available, which approach would you offer this patient? Offer HMA monotherapy while awaiting stem cell transplant, oral decitabine cedazuridine while awaiting stem cell transplant, offer HMA therapy alone and defer stem cell transplant indefinitely, pursue enrollment in a clinical trial evaluating the HMA BCL2 inhibitor combinations. I would consider all options and discuss with the patient. Excellent. I think I did my job. Thank you.
I think that's it. Thank you, Dr. Venopal. I think we have some time for questions, and I think we can take them from the floor and actually from the iPad here. So I'll start, maybe Maria and Sangeeta. So let's start with the first one. So do you change your management if treating a patient with low-risk MDS but EPO level around 500? So what is your take on this, Maria?
The first question is transfusion dependent or not? Probably with this value of endogenous EPO level, the patient is not going to respond to ESA, so this not be a very good option, especially in the if the patient is also in transfusion dependency, and probably we should treat with luspatercept or even imetelstat. It depends on the availability of the drug in this context. In Europe nowadays, we don't have access sometimes to luspatercept in ring sideroblast negative patients, but we also don't have imetelstat. So theoretically, we cannot treat this patient with more than ESA, but ideally, probably if available, we should choose first luspa, and if the patient did not respond or lose the response, move to imetelstat. The idea is to try to keep the patient in the most of the time in the transfusion independency and not exclude for different drugs available. So probably choose first the low toxic drugs like luspatercept, and after that move to another more severe regarding adverse event drugs.
The next question is actually quite interesting. Maybe Sangeeta, you can address this. So you are looking at a patient with low-risk MDS. You do your bone marrow test. Now you have a diagnosis. So low blast. Do you wait for the NGS or do you start right away?
I start right away, but if we have clinical trials, especially some of these subset of patients may have IDH2 or IDH1. So in our centers, we do have some of the clinical trials that are exploring the role of IDH1 and IDH1 inhibitors in lower risk MDS. So in that case, I would wait. But if this is not an option that is available in our center, then I would not wait for the NGS results. I would start treatment.
Excellent. The next question actually may be more than a question, maybe for Maria, because we didn't really talk about new drugs and things like that. So the colleague is saying, with so many agents being investigated in clinical trials right now, what is the role of ESA therapy, etc.? But the reality is that we didn't have an opportunity to discuss other clinical trials. You want to tell us, Maria, what's going on, because you are the leader on many of these studies, so this is maybe a good opportunity.
I think that the more advanced drug nowadays is elritercept, a novel TGF-beta inhibitor. Is currently on phase 3 trial, similar to the medalist design for luspa-naive patients, and is probably a more potent compound regarding TGF-beta inhibitors. And regarding another clinical trials in which we are participating, I think this is also of interest, and you are going to present some results about IRAK1 and 4 inhibitors. I think this is the role of the most advanced. And regarding the role of ESA, at least in Europe, until the results of Elements trials, we use erythropoietin stimulating agents very early at the initiation of the anemia, when the patient is in the non-transfusion dependent setting, because we think that in this phase of the disease, the drug is very effective, very safe, and can achieve a very prolonged period of time without transfusion. Element trial is now addressing if it is better for this purpose, EPO or luspatercept, we don't know, but I think that the mission is nowadays at least ESA are available in this setting.
Thank you, Maria. I think we can go, there's some other studies like ongoing, so we talk about the elritercept, we talk about IRAK4 inhibitors. There's also this kind of inflammasome inhibitors like the NLP3 inhibitor. There is actually some data that's going to be presented maybe with the low-dose oral hypomethylating agents. And then interestingly, momelotinib, that is this drug for myelofibrosis, also there. So we have a lot of movement in low-risk MDS. So we need a little bit more in high-risk MDS, but we saw the data with the next-gen BCL2 inhibitor, lisaftoxlax, from Dr. Benagupal. And there is one more question. I don't see anybody on the floor asking, so this is also for Dr. Benagupal. And it goes back to this issue of the mutational profile. So when do you consider a stem cell transplant in a patient with low-risk MDS? Is there a role at all for transplantation in low-risk MDS patients?
Yes. So if the patient has a higher mutational burden, so several studies have shown that the number of mutations in MDS or lower risk MDS is prognostic. So if the patient has more than 2 mutations, so they are at a higher risk for transformation to AML. And nevertheless, whether the patient is ready for transplant or not, we always evaluate the patient for stem cell transplant. And if and when the patient needs it, then the patient goes for it.
So going back to the first question, so you had the patient, you do your NGS, you don't wait because you're not really going to act on it. But later on, depending on response to ESA or luspatercept or imetelstat, if they have a high molecular burden, and if it's younger, maybe there will be a consideration for...
Yes, totally.
Excellent. I think that covers all the questions that I have here in the iPad. I don't know if anybody has any question from the floor. If not, we start Ash, right? So I'm super grateful for you guys coming here. I think there is actually some people maybe online. This is a great opportunity. Thank you for the organizers for putting all this together, and we wish you the best Ash possible. Thank you very much for the opportunity, and thank you, Maria and Sangeeta, for your talks. Thank you.
Thank you.
Eran todas, ¿no?
Sí.